Well, hi everyone. My name's Bronte Price from the Equality Network, and I'm a cis gay guy. Founded the Equality Network back in 2016 to educate and train people and organisations about how to be more LGBTIQ plus inclusive. And so one of the things we're going to do today is we're going to get to explore the intersection of the palliative care sector and the LGBTIQ plus community, see how progressive that sector is becoming, and particularly for people in the LGBTIQ plus community who may need palliative care. And it's my complete pleasure and honour to introduce Hannah Morgan, who is from LGBTIQ plus Health Australia. Hannah, welcome, and I'll get you just to introduce yourself and tell us a bit about your work with the PAL care sector, please.
Thanks, Bronte. It's wonderful to be here. So, yes, my name's Hannah. I am a social worker. I'm queer. I am very fortunate to work for LGBTIQ plus Health Australia on a very important project, which is really focused on LGBTIQ plus communities in palliative care, but specifically supporting healthcare professionals to build their confidence, their knowledge, and their capacity to provide inclusive care for LGBTIQ plus communities. So it is really an incredible project. It has involved research. We're developing education for healthcare professionals at the moment, which will be sent out free of charge, which is really important. And we will also be establishing a communities of practice. We've been doing lots of work in the palliative care sector to raise awareness about the issues that impact LGBTIQ plus communities.
It's fantastic work. It's been going for some while now, hasn't it?
Yeah.
When does the project finish?
It finishes up next June. So we're in the final stretch of the project where we're seeing everything come together. And it is really exciting. I have to say that we've been incredibly warmly embraced by the palliative care sector. There's absolutely an appetite for this information. People want it. They wanted it yesterday. So it's great to work in a space where we felt really supported and welcomed.
And the end result, the end product will be a series of e-learning modules. Is that right?
That's right. So we are co-designing, so working with LGBTIQ plus community members and healthcare professionals to co-design e-modules. So we'll be developing 4 e-modules that are for healthcare professionals. And I think it's really important to say that no matter where you are on your learning journey, I think that there'll be something in there for you if you're a healthcare professional and you're keen to learn a bit more about how you can be more inclusive.
Thank you. So they'll be released after the project finishes, around June next year?
They will come out, we're hoping, February next year.
Oh, wow.
So not too far away.
Great start to the new year. So let's get the language right, I guess, and let's get you to tell us what actually is palliative care.
Well, there are lots of definitions around, but after doing a lot of the research and looking at the various definitions, I think that one of the key things to note is that it is an approach that really aims to improve the quality of life of people who are facing life-limiting conditions. And it really aims to relieve suffering, to support people with their pain, but not only that, to also support people in terms of their psychosocial or spiritual parts of their lives and their journey that they're on. And so it's really more than just the physical, and often it involves a team approach. So a team will support patients as well as their caregivers or chosen family to support them around addressing their practical needs, their physical needs, and it also includes bereavement and bereavement counselling.
Yeah.
It's very much a support system that's available to people.
So it's whoever the person who's dying, and perhaps their family or chosen family nominates to work with them at end of life. It could include, for example, an end of life planner or a death doula, could it?
Absolutely. That's becoming more and more common. We conducted a palliative care survey in 2021, and people did tell us that they were kind of really interested in thinking about what other options might be available to them at end of life, including employing a death doula to support them. And so I think we're going to see more and more of that.
I think so too. I'm wondering if there are particular fears and issues and challenges that are faced by LGBTIQ plus people when heading towards palliative care compared with the general community.
Certainly from the research that we've done, I would say the biggest thing is the anticipatory fear. So it's the person who's always expecting that at any moment they could encounter an instance of being discriminated against. And what that can lead to is people don't access palliative care services early enough.
Yep.
And when they do, they still have that sense of, oh, can I trust this person? How trustworthy is this service? And discrimination can look really different in healthcare settings. It can be really obvious discrimination, such as being talked about at the nurse's station in an inappropriate way, or it can be that you've noticed that you're just getting treated a little bit different. So maybe the body language of healthcare professionals slightly shifts or changes. But I think as LGBTIQ plus people, we've all navigated healthcare services and experienced what that feels like. And so I think we are hyper vigilant to that and noticing that there's also the constant need to have to educate healthcare professionals while you're seeking treatment and care. And that can be incredibly draining to do that. There's also often quite a narrow understanding of what family looks like. So often there's a default position of everyone has a heterosexual nuclear family, or some version of that, which isn't too stretched. But really the concept of chosen family, which is particular to LGBTIQ plus communities, which refers to the people that person regards as their family, is really important for healthcare professionals to understand, to recognise that family does look different for different people, but that partners and chosen family need to be involved and included in healthcare decision making. And really the systems, as we know, the healthcare system, it's very heteronormative. It's been set up around assumptions that people are heterosexual, that they're cisgender, so that they're not transgender. And we see that everywhere in terms of documentation, the questions we're asked, all of those instances really create a feeling of not being safe in palliative care settings. So many of the barriers are across the healthcare system. I would also say that end-of-life planning, sometimes those conversations aren't raised early enough, or the substitute decision maker or the person who you've decided will make decisions for you in the event that you can't isn't really identified by the healthcare professional in the correct way, or that conversation isn't had, and that can lead to issues. There's a lot there, but another thing I'll just add is sometimes family who have been estranged might come back into the picture, and perhaps the individual who's seeking palliative care or receiving palliative care might have challenging relationships with those people. They may not respect who they are, their partners, their chosen family, etc. So sometimes that side of things can be really challenging for people.
That anticipatory fear that you talked about early on is, we've got buttons all over us, haven't we? And we kind of wait for the next incident where we're going to be either hurt or insulted or discriminated against or perhaps harassed in some way. So it's a very real thing for queer people, isn't it? Yeah.
Absolutely. I think
I'm wondering whether I want to dive into the family members who have been estranged, and that seems to be quite a common theme across the queer community. Are there ways in which documentation such as not a will, but perhaps an advance care directive or other piece of documentation can spell out what those wishes are of the person who's, they're very exposed, they're very vulnerable, they're about to undergo palliative care. There's some way of blocking those family members from even being on the scene in writing?
Look, I think that the best thing we can do, and what I've done personally, even though I'm not needing palliative care, is to look at advanced care planning now. Whether you're in a situation where you're unwell or not, it doesn't matter. You don't have to be unwell to actually think about who you might want involved in your care if you were to become unwell. And in Australia, there are lots of fantastic resources to help guide you through the different ways that you can document your wishes. And I would recommend Advanced Care Planning Australia's website as a starting point, because state to state, the terms used and the names of the various documents that you can record your wishes on, it's different. So that website will take you through and actually let you see, if I'm in, for instance, New South Wales, I can see what's available to me and the different steps that are involved. I think that's really the formal way of doing it, and that's a way that for me, when I did it last year, was quite empowering, because I felt like I've gotten a bit of control over a situation, rather than having to potentially navigate that if I'm unwell. And I think that it's hard to have these conversations. It's really hard to think about how do we want our end of life to look, and who would we want around us to support us. Those conversations aren't easy, but I think that if you can have them before you're faced with some kind of illness, that's a good idea. If you don't have the opportunity, then initiate those conversations early with your healthcare providers, because there are ways that we as LGBTIQ plus people can protect ourselves.
Okay, and your point is completely spot on. It's really important to get these documents completed when you are well, when you can do them with a clear mind, rather than when you're at the end of life, perhaps. And also to get them signed off by the medical professional, by your GP, for example, so that it's official. It's also really important to make sure that someone knows where they are, where is that document located, so that when the time comes, it becomes part of that whole process there. I'm wondering if there's an intersection between, and I'm not sure there's any evidence of this or not, between those fears and challenges for people facing palliative care, if they're greater in some suburban areas of each capital city, or if they're greater in rural and isolated towns and places, or that's just a kind of observation that's not happening. What do you think?
Yeah, so geographically, there are different challenges for people. Interestingly, when we did our National Palliative Care Survey, we actually saw that LGBTIQ plus people who were living in rural areas were more likely to have engaged in some kind of advanced care planning, or more likely to be clear on who they might see as the person who would make their healthcare decisions. And I think that was interesting. I can't say why that was the case. I'm making assumptions here, but we know that there are particular barriers in rural and regional areas in terms of the variety of services and the different options that you might have access to, the sometimes lack of privacy and confidentiality that might be there, and that you might not be able to get the particular treatment that you need in your local area. And I guess, again, and this is across the board really, but the fact that a lot of palliative care settings are faith-based, operated and owned. And so for some people, not all people, because we know LGBTIQ plus people are of faith as well, and they might actually preference being in a faith-based facility. But I think that the options are even more limited. If you're in a regional area and you've got two options that are owned by a faith-based org, and that's a concern for you, that limits your options. For another person, that might be a great option. But I think it's important to recognise that a lot of LGBTIQ plus people have felt uncomfortable about potentially being exposed to religious views that are quite conservative. So that's another issue that came out really strongly in our research.
Okay, and the simple things like the crucifixes or the statues in the in either the forecourt or in each room, for example, or the prayers that are not solicited, that are unsolicited, it's just something that would cause some fear. And in rural and regional areas, I guess there's the alternative then is, to be separated from your home, but also your hometown and your friends and perhaps family where the blood are chosen, and you might be 300 kilometres down the road and not know anyone in that, well, clearly in the facility, but also in that town, possibly. Yeah. Okay.
It is individual. Like I've definitely heard of circumstances of people who feel much more comfortable in the regional or rural area where they are, and it's actually heading into the cities that make them feel most uncomfortable. And so it is dependable, but I think we know from the research that there are those barriers, and it is something that did come through.
I wonder whether you can just identify a couple of the biggest challenges that you think, and not just barriers, but challenges that you think are facing queer people when they seek or undergo palliative care.
I think some challenges are really about navigating the healthcare system. And I've already mentioned this, but I do think this is like probably the key thing, is that you might experience many instances of microaggressions and discrimination that makes you feel like you're not safe. And so that could be at intake, you're filling out a form and you can't share your pronouns. You get misgendered at reception. You go in and you get asked intrusive questions by a specialist. Assumptions are made around who you want involved in your care. Not everyone is open or wants to tell a healthcare professional that they're LGBTIQ plus, and I think it's important to emphasize that that's fine. You don't have to disclose that information. That's your private information. But I think what we see is healthcare professionals don't shift their practice unless they know that someone is specifically LGBTIQ plus. And so I think that one barrier is that unintentionally, and this is about systems and paradigms and worldviews, unintentionally, healthcare professionals do just default again to that heteronormative, cis-normative worldview. And unfortunately, I know that many healthcare professionals don't want to perpetuate these things, but they're not really being trained to do it differently, and they're not being given the skills to develop their confidence in that space. And so it's really the system, and navigating the systems is hard enough without having to then constantly educate people, correct people, you know, be on edge, be hypervigilant about your own safety. You know, and even with bereavement, we've seen in the research, there's a term called disenfranchised grief, and or complex grief as well. And it's when, you know, for example, you might have someone who's a partner of someone receiving palliative care, but no one's recognized them as the partner. Or maybe they haven't disclosed that, and that's okay, but then they don't get the supports that wrap around them at the time. And so I think that's something that we really need to look at in terms of having LGBTIQ plus inclusive services that specialize in bereavement and counselling. And I think probably another thing I would say is that I think there's like relative comfortability with supporting some parts of LGBTIQ plus communities if you're gay or lesbian, but there's a lot less competence and knowledge around supporting people who are trans and gender diverse, and people who are intersex or even bisexual as well. So I think that there's different levels of comfortability, and that comes down to education and training.
So it does. And I think, which comes back to your e-learning modules, right? But I think also you can understand at a certain level the default position of healthcare professional or palliative care professionals who, you know, they're busy, they've got high caseloads, and they will go back to the default position and assume that everyone is straight, or treat everyone as if they're straight. And that's where it's so important for them to understand some of the nuances, I guess. It's very much the case, I think, that it's about, one of the issues is about non-recognition or non-respect of whoever the partner is, and deferring again to blood family, to perhaps the parent, the mother or the father of the person who's dying, rather than the husband or the wife who's LGBTIQ plus possibly. So you've spoken about education as being one of the solutions. What are some of the other solutions? I guess freeing up the admin kind of impasse of those onboarding forms. What else is part of the solution to the issue, do you think?
Yeah. Look, I think if we're thinking about LGBTIQ plus communities, and I'm thinking about myself, we have to be more willing to have conversations about death and dying and take part in those and have those conversations in our communities. And I think there needs to be more done to raise awareness for LGBTIQ plus communities about the options that are available to them now to do advanced care planning. So I think there's something on our end that we can do to really protect our rights at end of life. I think that another thing that's important is if you're a service providing palliative care or you're a healthcare system, thinking about if someone was to come to our service, how would they know that we're safe? What are we doing to signal that we are inclusive? And I ask this question of lots of different services because I often, I do meet and talk to many services across Australia, and I often have a look at their website and see the types of promotional material that they're putting out. And I don't see myself or LGBTIQ plus communities in that imagery. So I think it's that notion of if you can't see the thing, how do you know it's there and you're not thinking about it? So it's visibility, it's really important. But you can't just slap some posters on the wall and have some rainbow flags if you're not doing the real work behind the scenes. And I think that, yeah, projects like the one I'm working on, there's also other projects happening across the country where there are LGBTIQ plus people really doing a lot of amazing work in healthcare systems and settings.
Yeah, thanks. So it's about being inclusive rather than saying you're inclusive, right?
Absolutely.
Yeah. Can you just highlight maybe one or two of the most exciting initiatives you've seen happening for the queer community in palliative care across, your travels that you've seen?
Definitely. So in Geelong, so in Victoria, there's a brilliant initiative through Barwon Health. So they actually have an LGBTIQ plus coordinator coordinating a project which is focused and working very closely with their palliative care team to support them not only in training but having conversations and really looking at how is that service being visible. They've developed a great resource through that program. Also, ACON in New South Wales developed a palliative care toolkit. ACON do brilliant work in this space, and it's the first of its kind. There's no other toolkits that I've seen that are really fit for the Australian context, and that's available on their website. And ACON are great. They're really at the front line and out in the communities. My project is more around building capacity of healthcare professionals. But certainly it's those resources that are starting to make their way into hospital and inpatient settings and in community palliative care settings.
Yeah, so there are some concrete things that you think, I believe, could be done to alleviate some of those fears that we spoke about earlier, that lead to queer people perhaps either delaying or just not undertaking palliative care at all. If you were able to just nominate two quick changes that organisations, palliative care providers could make, or allied health professionals could make, what would they be?
Yeah, I mean, I'm thinking that having a conversation in your organisation, do you have a diversity policy? Is there anything that someone could point to say we are inclusive of LGBTIQ plus communities? I know medical professionals have told me they wouldn't enter a facility if they couldn't see something like that, those who are LGBTIQ plus. Another thing is to educate yourself around pronouns. There's so many resources out there. It is incredibly important that we become literate and confident in using people's correct pronouns. And that will be part of our education. But I would suggest you don't wait until next year to learn about that. And if you're nervous and it feels uncomfortable to you, that's really normal. There are ways that you can navigate making mistakes. It's okay to make mistakes. One of the couple of things I say is just get started by wearing a pronoun badge or introducing your own pronouns, which I actually didn't do today. My pronouns are she, her. And you get more comfortable with the idea then, and you open a conversation up, and you signal that safety, which is so important. And if you make a mistake, just correct yourself and move on. There's no need to make a big drama and fuss about it. That's the last thing LGBTIQ plus people want. And you just keep trying. That is so important.
And you just keep practicing, and you kind of normalize it in your own brain. Not everyone's pronouns are my pronouns or your pronouns. And we get used to that diversity. Is there room currently within the palliative care sector for patients to nominate chosen family instead of blood family as their close contact? Is that already possible, or is that still a bit of a work in progress?
Absolutely, legally, absolutely. And that's the case for people who are not LGBTIQ plus, because we know it's not just LGBTIQ plus people that may not have close relationships with their family of origin. And so I don't want to do a 101 on the legislation, but you can indicate the person that you want to make those decisions for you. I think the tricky thing is if you don't have those conversations and document them, sometimes the legislation is such that there could be someone who you're not really wanting to make the decisions gets put in that position because it defaults to them. So it is important to have a conversation with your healthcare professional around that and just clarify that. But absolutely, like this is many people don't have good relationships with biological families. So I think there is something you know, amazing about LGBTIQ plus communities, and that the concept of chosen family is that I think there are people outside of LGBTIQ plus communities who would really resonate with that concept as well. And so it is absolutely something that can be done. You're not necessarily going to be forced into having someone make those decisions that you don't want in the picture. But I recommend you look into this earlier than waiting to be reactive in the moment. And anything can happen to us. You know, the difficulty is you need to have capacity. So you need to have cognitive capacity. So you need to be able to tell people and make an informed decision about what you want. If you lose that capacity, unfortunately, that's when the kind of legislation kicks in, and you might find that that doesn't work in your favor. And so look into it early, look into it now, do the advanced care planning, and you'll protect yourself.
Thank you. I think that's the takeaway message, Hannah. I think that you know, there's evidence out there that there's a fairly low proportion of older members of the general community who have not got a will, haven't got a power of attorney document filled out, haven't got an advanced care directive filled out. My suspicion, and I'm not sure why I've got this suspicion or this assumption, is that the figures are even higher in the queer community than they are in the general community. Partly, I guess, through, as you said really early in this conversation, distrust of all sorts of societal systems that leads us to think, well, it's, you know, I'll be gone, it won't be my issue, or, you know, I'll just let fate take me where fate's going to take me. So I think the key takeaway from this chat is get it done, get the documentation secured, while you still can, while you're well and fit, and you have that cognitive, you know, capacity, rather than, you know, you've got 6 weeks to live and you just, as you said earlier, you've got to educate those around you all of a sudden when you're so vulnerable and so unwell. So that's been a lovely chat. Thank you very much. Is there anything you want to say before we finish off?
Look, I think that the one thing I'd want to say is I know that some of this conversation has been quite critical of the healthcare system and healthcare providers. And really, we don't want to be critical in the sense that we don't want you to be shamed. We want you to be welcomed in. We really welcome you in to learn these new skills. It's okay if you don't get it right, but please engage with us, and please come and do the training when it's out next year. Go and educate yourself. The world has changed, and person-centered care is actually not possible without addressing people's different individual needs. So I think that that's just something that I'd like to say to end.
Thank you. Thanks very much, Hannah.
Thank you.
Appreciate your conversation today.
Thank you.